Welcome back to the deep dive. Today we're really getting into the very definition of what it means to be an emergency medicine specialist.
We are. We're looking at the core expectations, really, set out by the Royal College,
Specifically, we're locking in on Specialty Learning Outcome 3, or SLO 3, from the 2021 curriculum.
which is, let's be honest, it's the non-negotiable standard for critical care in the ED. It's the big one.
It really is, and for anyone aiming for that specialist register, SLO 3 is the absolute benchmark.
It proves you can manage the most time-critical, life-threatening conditions. And it's not just about technical skill. It's about, crisis leadership.
And the outcomes wording is so precise. Identify sick adult patients, resuscitate and stabilize.
And know when it is appropriate to stop.
And that last clause, that's the real kicker, isn't it? That's where it moves beyond pure clinical expertise.
Oh, absolutely. That's where you get into professional identity, ethical maturity. The whole journey is about getting to that entrustment decision.
Right. It's not a tick box exercise.
Not at all. It's a panel-based judgment. It's a group of your peers saying, yes, you can function independently at a consultant level. It's a huge vote of confidence.
And to get that trust, the curriculum is clear. You can't just be good at one thing. It's about integrating across those three professional domains.
Yeah, that three-pillar model is designed to make sure your expertise is, well, holistic.
So let's break that down. How do those domains actually apply when a patient comes in who is critically unwell?
Okay, so let's start with domain 3, professional knowledge. And this is, it's so much more than just knowing the algorithms off by heart.
It's the deep stuff.
It's the deep stuff. It's a profound understanding of the core science. It's knowing the national guidelines, like the Resus Council UK guidelines, inside out. And it's knowing the legislation that governs what we do.
Okay, then we've got domain 2, professional skills.
The hands-on part, the technical application. Can you actually perform the invasive procedures when the pressure is on?
But it's also the crisis resource management side of things.
Exactly. It's not just about what you can do with your hands. It's about how you can lead the team, delegate, communicate when everything is happening at once.
And then the unifying force is domain 1.
Professional values and behaviors. This is the ethical bedrock. It's about compassion, professionalism under extreme stress, and, crucially, handling those end-of-life conversations and decisions in the ED.
What I find fascinating is the emphasis on anticipating problems. The curriculum says early identification of deterioration.
Yes.
It's not enough to react when the patient is already crashing. How do you actually assess that skill, that sort of pattern recognition?
Well, that's where clinical experience and the complexity of the cases in your portfolio really matter.
Right.
We need to see evidence that you're spotting the subtle signs. Think about neutropenic sepsis. The patient might look okay for a minute, but a good trainee sees the trajectory and acts preemptively.
And that's why the curriculum lists these really specific high acuity scenarios. They're designed to test you.
They are. Take DKA, diabetic ketoacidosis. It's a prime example because it's a physiological tightrope walk. You're managing fluids, acid base, electrolytes all at once, trying not to cause cerebral edema. It's a real test.
Or something like a tricyclic antidepressant overdose. That's a toxicological nightmare.
Absolutely. Cardiac and neurological instability hitting you at the same time. You need your ALS principles, but also very specific tox knowledge. These high-risk cases are how you prove the depth of your clinical acuity.
Let's shift a bit and talk about the technical pillars, the nuts and bolts of domain 2. For higher specialty trainees, the expectation around airway management is it's a lot higher.
It's significantly elevated. At the HST level, you're not just competent, you are expected to be the expert.
The definitive airway manager in the department.
Exactly. You're the one people turn to for the complex airway, for the difficult ventilation strategy. You're not just doing it, you're leading it and supervising the whole MDT.
And that same level of expertise applies to circulatory support, I imagine.
Paramount. You have to demonstrate a really sophisticated knowledge of fluid management, pressors, all the shock states. And they place a huge emphasis on time-critical hemorrhage.
Like a major trauma or a ruptured ectopic.
Precisely. You need to show you can execute those protocols fast.
And a lot of the evidence for this comes from the external courses, doesn't it? ALS, ATLS, APLS.
It's established the foundation, yes.
Yeah.
They prove, the drills. But here's a key insight.
Go on.
Achieving instructor status in those courses is valued much, much more highly than just having the certificate.
Okay, so why is being an instructor so much better as evidence?
Because it proves a whole load of non-clinical skills. It shows you understand the protocol so deeply you can teach them. That's Domain 3 excellence. But it also shows you can supervise, give feedback, stay calm while assessing others.
Which are all leadership skills.
Exactly. And it links directly to other parts of the curriculum, like SLO 9 on education. It's comprehensive proof you've mastered it, not just scraped through.
Right, you can run the system, not just function within it. That makes sense. Let's talk about the progression then, because the curriculum draws a very clear line between ACCS, core training, and HST.
It does. The line is really about the shift in entrustment. It's about moving from individual action to systems leadership.
So in ACCS, what's the expectation?
In ACCS, you're entrusted to spot the sick patient, start resus, be a good team member. You make a plan for the septic patient after they're stabilized. You've got a supervisor on call. The focus is on safe, individual patient care.
But then you hit HST and the goalposts move significantly.
They move to a different pitch. As an HST, you have to be able to manage all life-threatening conditions. You're the expert in advanced support, and critically, you're the team leader.
It's the shift to mastering crisis resource management, CRM.
That's the term. And practically, CRM is all the non-technical stuff. It's effective delegation. It's making sure there's closed-loop communication. It's managing your own cognitive load under stress, allocating resources, and keeping the team psychologically safe. You're the one taking that 10,000-foot view.
It's interesting how SLO 3 is the foundation for other things, too, like pediatric critical care and SLO 5.
It provides a single, robust standard. The core principles of recognition, resuscitation, and leadership are the same, whether it's a 70-year-old in cardiac arrest or a 2-year-old with sepsis.
Let's pivot to what can be the hardest parts to assess, that leadership piece and the ethical core, the stop clause.
This is where a very specific assessment tool comes in, the ESLE.
The Educational Supervisor's Leadership Event.
And it is absolutely instrumental for this SLO.
So what is a supervisor actually looking for in an ESLE that proves you've met the standard?
They're looking for your ability to lead the resuscitation area as a whole.
Not just one bay.
No. They need to document you managing the flow, maintaining an overview of a number of cases at the same time. Maybe you're managing a complex post-resus patient while also delegating tasks for a new chest pain and advising on a PEGS case.
That is a world away from just running a single arrest code.
A world away. And the ESLE has to show you doing this in both adult and pediatric contexts. It proves you can manage the whole high-stakes environment.
Okay. And then there's the ethical mastery, that know when to stop.
Which is about determining futility, understanding the legal frameworks around sealing of care decisions, DNA CPRs, and all of that.
And which legal frameworks are we really talking about here?
Primarily the Mental Capacity Act. You have to be competent in assessing capacity, making best interest decisions, and respecting advanced directives. Domain 1 demands that you can communicate the rationale for these decisions clearly and compassionately.
And how do you capture evidence for something that sensitive?
The case-based discussion, the CBD, is the tool of choice. You can't really assess that level of reflective judgment in the middle of a chaotic resus. The CBD lets a supervisor probe the why and the how of your decisions afterwards. It's perfect for Domain 1 evidence.
So this all builds up to a massive triangulation of evidence. Exams, WPBAs, and then final panel judgments.
Exactly. And your WPBAs have to be targeted. A mini CEX is great for observing your primary survey on one patient. It confirms immediate competence.
Whereas the CBD, as you said, is for reasoning, to explore your justification for choices in a massive hemorrhage or a complex overdose.
Precisely. And then your procedural skills, your chest drains, your central lines, they're captured by a DOPS or an ASAT. They tick the technical boxes for Domain 2.
But the real cornerstone for mastering those high-stakes, low-frequency events and the non-technical skills is simulation.
High-fidelity simulation, HFS. It's invaluable. It's where we can safely test your command structure, your communication when things are going wrong.
And there are mandatory scenarios you have to cover, aren't there?
There are 5 core ones.
Yeah.
Front door VF arrest to test pure ALS leadership. Cases needing high diagnostic skill, like neutropenic sepsis or DKA. A major hemorrhagic shock scenario, like trauma or a ruptured ectopic.
Right.
The really technical challenge of an unresponsive TCA overdose.
And the 5th one loops us right back to the start.
It does. The mandatory end-of-life scenario. This is the ultimate test of the know when to stop part. It assesses your ability to have those difficult conversations about sealing of care under pressure.
So to bring it all together, for any trainee listening, SLO 3 really comes down to a triad for entrustment.
The triad is crystal clear. 1, clinical expertise, technical skill, and sharp diagnostic acuity. 2, ethical maturity, sound judgment in end-of-life care. And 3, Systems leadership, the proven ability to run the whole resus area.
So what are the three big actionable tips for a trainee tackling this? Number one must be about the ESLE.
Absolutely. Be proactive. Don't wait until the end of your training. Get those ESLEs done early and make sure they show you managing the whole department, adult and paid eds. That 10,000-foot view needs to be documented.
Okay. Number two.
Use your CBD strategically. Don't waste them on simple stuff. Target them on the ethically complex cases, the withdrawal of care decisions. That's your high-yield Domain 1 evidence.
And number three.
Treat simulation as gold standard evidence. Maximize it. Focus on practicing your CRM, your communication, your resource allocation. Those are the skills that define HST-level leadership, and they are easiest to document in SIM.
At the end of the day, when you look at what SLO3 demands, it's about a profound commitment to safety and leadership.
It is. And maybe the final thought for people to take away is this. Does your technical brilliance really matter if you haven't also mastered the humility and moral courage to know when to stop, to recognize the limitations of medicine, of your environment, of your team?
That integration of ethical maturity with clinical power.
That's the true essence of the emergency physician.